Hi everyone, I'm Alexandria Root, and today we're going to talk about lung cancer with sepsis. So this is my case study. I'm a student from Eastern Michigan University, and I'm getting my bachelor's and my master's in dietetics. So my case study was actually done at McLaren-Lapeer Region Hospital. So to learn a little bit more about me, please see the About Alex Root page in your blue presentation folder. What's on the menu? Well, we're going to talk about our disease background, our patient, what our present illness and medical treatment is, the peer-reviewed articles, and my conclusion. Today we're going to start off the right way, and we are going to see a t-shirt. My mentor does this at the beginning of every class. This says, "Caution, I'm radioactive." Well, fun fact, receiving radiation does not make you radioactive. On to our disease background. We're talking about lung cancer, squamous cell carcinoma. It's a type of non-small cell lung cancer. Lung cancer was actually first documented in 1912. It was documented by Isaac Adler, who said, "This is one of the rarest diseases of the time." That's my best impersonation. He actually described lung cancer after seeing similarities in autopsy reports from Western Europe and the US. It's also known as bronchogenic carcinoma. The tumors in the lung are actually developing in the parenchyma or in the bronchi. It's known in the US as the leading cause of deaths related to cancer, and since 1987 in women, it's actually been responsible for a greater number of deaths than even breast cancer. That's shocking. So, our clinical manifestations, we've got malignant tumors, which may lead to hypercalcemia, then turns into kidney stones and pain. We've got blood in the sputum with a cough, metastasis to the brain, paraneoplastic syndrome, which is actually really common in lung cancer. It comes with a loss of memory, muscle tone, fine motor skills, and walking ability. Shortness of breath is very common, xerostomia or dry mouth, poor appetite, they will be immunocompromised, and they're dealing with fatigue. So our etiology. Well, our major modifiable risk factor, it's pretty obvious, it's smoking. It's related to 90% of cases. There are other risk factors including secondhand smoke, carcinogens like asbestos, uranium, radon gas, which is actually the number 2 cause. Radon gas exposure can happen in basements. Water, rocks, and soil can also emit radon gas. Metal exposures, including nickel, chromium, arsenic, and polycyclic aromatic hydrocarbons. We can also have hazardous chemical exposure, particle pollution, and high genetic predisposition. Lastly, treatment for radiation for another type of cancer can actually make you more susceptible to lung cancer. It can increase that risk. So, for example, this is particularly true for breast cancer. It's not really uncommon for patients with breast cancer being treated with radiation it's not uncommon to be diagnosed with lung cancer. And nicotine exposure actually increases the odds of both of these cancers. Next, we have our medical treatments. The biggest thing that I want to emphasize is interdisciplinary communication. So that means family and all of the care team. Referrals and follow-ups are critical. Monitoring ventilation, pain, anemia, and oxygenation will be necessary. Radiation and chemotherapy lead to the immunocompromising nature of this thing we're battling, right? So we have to treat comorbidities, and we may even need to provide comfort measures in the end. The nutrition care manual and clinical judgment, of course, they're necessary. So protein, and I want to throw this out there, it depends, but what the NCM actually likes to recommend is 1 to 1.5 grams per kilogram per day. For energy, 25 to 30 kcals per day. For fat, we want MCT. We want that because it's an immediate source of energy, and it goes to the liver turns into ketones, and when we're fasted, ketones are actually more efficient energy for the brain. We also want to increase fat density because we want more calories coming in for our patients to ensure that they don't lose weight and we don't end up with cancer cachexia. We also want to include fiber. The goal for women is 25 grams per day. I'd like to see a little bit more. There's been a lot of good research showing that increasing the amount of fiber can help with strengthening the intestinal walls, and males need 38 grams per day minimum. More on fiber. We want an insoluble fiber to increase fecal bulk, especially with diarrhea, but we're also going to keep in mind that we're going to adjust fiber intake with prolonged and or early satiety, bloating, gas, diarrhea, and constipation. We really want to include nuts, whole grains, potatoes, green beans, and cauliflower. Now, my daughter loves to call cauliflower ghost broccoli, and that's why you'll see the eyes on the little cauliflower piece. So dentition is going to be super important, hence why the dietitian is thinking about, does this person have dentures? We may need to have a texture modified diet, maybe a little extra fluid if someone has a dry mouth. If someone has a lot of inflammation, we're going to want more protein. If they have dysphagia, we're talking to SLP. And with that, typically what we're going to see is a soft diet with liquid and protein, or even a pureed diet. But it depends on the patient. So, nutritional treatments can also include food safety. That's going to be my number one priority, talking about safe food handling. This person's most likely immunocompromised, especially if they're getting chemotherapy. With that, we need to talk about neutropenia, and anything under 500 actually means we're very immunocompromised. So with that, we're going to schedule and promote oral intake, and we're going to talk about food tolerance. So the GI might be functioning a little bit differently with chemo, might be a little bit slower. We could end up with nausea, vomiting, diarrhea, gas, and GERD, basically anything on the back of the Pepto-Bismol box. With that, we want to talk about foods that are better tolerated, and that includes mashed potatoes, white rice, chicken noodle soup. We're going to take small, frequent meals 5 to 6 times per day, and we're scheduling fluids, again, for tolerance. Nutritional treatments can include when life gives you lemons. Of course, I wore my lemon shirt. Zinc deficiency may actually alter taste, so you can end up with dysgeusia, loss of taste. Lemons or chewing gum may help shock the taste buds and make eating more tolerable, but also more enjoyable, because food for people, it can be the one thing they control while they're in the hospital. Chemotherapy taste alterations can be seen in as much as almost 70% of patients, way more than 30. So for non-small cell lung cancer, the classic RD answer, as I said earlier, it depends. We want to focus on our TNM stage. This is tumor, node, and metastasis. The higher the stage, the lower the likelihood of recovery. This is very intense information because worldwide 1.8 million deaths were seen in 2020 related to lung cancer. This is actually referred to as an epidemic, and it doesn't seem like one we're talking about as much as we should be. So for non-small cell lung cancer, that's actually how squamous cell is categorized, what our patient has. Recovery really is going to depend on the stage, and prognosis has actually been seen to be poor if there's poor performance status when the patient is diagnosed. So this could mean weight loss, anorexia, metastasis, and it could also mean metastasis in the liver or the skin, decreasing their likelihood of survival the most. So more on TNM. We want our patients to understand, but to do that, we have to understand. We need to know what's going on. So for the T, tumor, we want to know the size and the location. The bigger the tumor, the higher the number, which seems pretty obvious, But if it's in other locations, the number is also going to be higher, even if the tumor is smaller. N for lymph nodes, we are looking at the number of lymph nodes affected and the size. So the greater the number of nodes, the greater the N. The bigger, the higher the number. So metastasis, we're talking about the location, but we're also talking about the number of mets. So if it's in another location, the higher the number. If we're talking about the greater the number of mets, the greater the M. So with this tumor category by size, we're going by centimeters here. So T1 goes through A and C, so 1 to 3 centimeters. We have a great description here. We are actually going to focus on T4, but T2, A, and B are 4 to 5 centimeters, T3 is 7, and T4 is actually 9 centimeters. With our patient and with T4, it's same lung, but different nodules and different lobes. So it's invading various parts of the body. Our patient actually had it in both lungs. It was bilateral. So really interesting fact, with measuring a tumor, we're measuring the solid component and we're measuring a single long axis. So whatever part is going to be the longest is the number we're taking down. We're not doing the entire lesion because if it's soft and it's not the solid component, it doesn't count. So a little bit more, we're diving into additional descriptors. First, when our patient was first diagnosed, they had multifocal ground glass adenocarcinoma. They had multiple lesions with a growth pattern that is lipidic. Lipidic means scaly. It's not a word that I was very familiar with, but definitely something I want to emphasize here because it gives us a good description of what this cancer actually looks like. We ended up with diffuse pneumonic type adenocarcinoma. It's a morphology of the tumor, means it's consolidative or infiltrative. And yes, this tumor did infiltrate other areas of the body. It's also not in situ. It isn't just in the original place with our patient. So proper screening. We want to help the patient start off right. Proper screening decreases overall mortality by 6.7%. With proper screening, it takes like 25 seconds. That's super easy. So ideally, we want preventative nutrition and education. Realistically, we're probably relying on screening. So screenings are actually offered to women and men. They're 55 plus. They've smoked at least 30 plus packs of cigarettes per year, and they stopped smoking 15 years ago or less. Prevention. We want to focus on occupation. Is this person sedentary? Are they smoking? Did they receive radiation? What do their genetics look like? We want to talk about, have they aged? Are they dealing with pollution? And are they dealing with pulmonary diseases like COPD? Physical activity for recommendations. We want to highlight that it needs to be consistent. Restricting energy in moderation can be recommended. Increasing fiber intake with water intake. Increasing PUFA intake, polyunsaturated fatty acids, for reducing inflammation. And then we're also reducing sarcopenia risk via the DASH diet, if at all possible. So prevention of lung cancer actually includes utilizing the lung-gut microbiome, which we're going to talk about in a little bit. Now we get to meet TK. So diving into her intro, this is TK. Her daughter, her power of attorney, brought her in. Personal data includes that she's a mom, clearly. She has 1 son and 2 daughters, so 3 surviving children. She had another daughter that passed after battling with breast cancer. She was a widow, lives alone, 62-year-old Caucasian female, and as she comes into the ER, she's alert and awake. This was 2/21/24 at McLaren, and she said that I was home, I was feeling tired, and it's really hard to breathe. Diving in a little bit deeper to her family tree, we see a lot of lung cancer and breast cancer, and even a combination of the two. All of the family members you see here have actually passed away prior to TK dealing with this. Smoking contributes to about 80% of lung cancer related deaths, which is highly alarming and very significant. Something we should talk about more. Social history, we're getting a little more personal. So yes, she was a past smoker. So for 40 years and about 7,300 cigarettes, that's a lot. She denied alcohol and illicit drug use. She was a Lutheran. Leisure activities were unknown. Regular diet with a good appetite was reported. And she's a retiree with an unknown past education and occupation. Her social determinants of health determined that money was not a concern, which is nice to know because she was dealing with cancer. It can be quite expensive in America. So upon admission, so again, 221, she had shortness of breath, sepsis, was febrile, hypotensive, and tachycardic. She reported a decreased quality of life, and labs were ordered. These labs include urine, so it was positive for a urinary tract infection, sputum cultures, positive for pneumonia. The PCR for influenza, COVID, and RSV were negative. And then she also had the lupus anticoagulant test, which was negative. She was positive for blood cultures with 3 different types of pathogens, some bad bacteria. And next, we're going to dive into her CBC and BMP. So our patient has the following things. So low potassium in cancer can actually be because her body is fighting so hard and her electrolyte levels are suffering. So with calcium, low calcium in cancer, as I noted before, it's actually pretty contradictory to dealing with hypercalcemia related to tumor activity, which is also possible. But with low hemoglobin, she could be iron deficient, which means that that's pretty common in cancer patients or patients with cancer. And so is low hematocrit, which has been linked to poor prognosis. High white blood cell count is pretty obvious indicator for sepsis and cancer because her body is fighting so hard and her white blood cells are doing a lot of the work. But again, it's best not to look at the patient, or it's best to look at the patient globally, but not to focus on one specific lab. Okay, and next we have our elevated alkaline phosphatase. If we have that and hypercalcemia and bone pain, this is a clue that metastasis in the bones has occurred. So this can present as bone pain and osteolytic lesions. We can also see adrenal metastasis. Adrenal metastasis and lesions. They're also common. A PET scan can determine if the lesions are malignant. Brain lesions can be seen in as high as 20 to 30% of patients at diagnosis. That's scary. And if a disease is advanced, then it's really common to see these symptoms after liver lesions have become present. Our patient does have low magnesium. This is because her body is fighting so hard against the cancer. It's displacing using up some of the magnesium in her body. And her initial diagnosis was actually done on 222. Of course, we know she's septic because of the bacteria in her blood. That's primary priority. We have pneumonia, bilateral, so in both lungs, dyspnea or shortness of breath, primary cancer of the left upper lobe, UTI, pain in the back, which is primary, in the right hand. This was related to a past fracture, and in the legs bilaterally. What I'm hearing the patient say, just by looking at the chart and reading this, I don't know if it's in her muscles or in her bones, but it is in a lot of areas of her body. So my question is this pain muscular or in her bone? So has the cancer moved to her bones? Lastly, she has anemia and neoplastic disease. This is related to her cancer chemotherapy. So past medical history. Her PMH. She was independent in her ADLs and IADLs. So she was actually modified, which means she was using her cane, but she was still able to do her activities of daily living and her instrumental activities of daily living. She was stage 4 lung cancer with a very poor prognosis. She was on a BiPAP machine receiving O2. She had a CPAP unit at home, and this was for her obstructive sleep apnea. And she also has a history of breast cancer. She had a cesarean section times 4. So for each of her 4 children, she had a double mastectomy, resection of her lungs, breast biopsy prior to the mastectomy, thyroid biopsy, a knee surgery, and an elbow surgery, tonsillectomy when she was a child, which is why we have no idea what the date is, and a Mediport, which is a central venous catheter for her chemotherapy treatments. Nutritional history. We do know that she was on a regular diet with regular texture and thin liquids. She was self-feeding because she was quite independent. No previous aspiration was noted. No food allergies were known. Supplements actually did include some things that are a little more anti-inflammatory, like omega-3 fish oil. She had milk of magnesia, which is something we need to pay attention to so her magnesium levels don't spike, which can be kind of an issue when using this product, but she was dealing with a lot of constipation. And then we have vitamin B12, cyanocobalamin. With cancer treatment, we do tend to use a lot of our B12 in our energy pathways, so supplementing may be necessary because a deficiency could present illness and medical treatment. So something that I was very excited about is that there are actually cancer vaccines coming out. There are many different types, but we can also do surgery, radiation, chemotherapy, targeted drug therapy, and then there's actually nanomedicine in lung cancer immunotherapy, which I thought was fascinating. But diving into her present illness, she had an ongoing battle. It was in both of her lungs, so squamous cell carcinoma left and right. She had a confirmed case of this after diagnosis, but she also had 2 chest x-rays that revealed that she had prominent interstitial and patchy opacities on her lungs bilaterally, so in both lungs, and they were more pronounced than her last exam. Then 222, she had a CT. This was actually because she had hypoxia, so very low oxygen in the blood. She was emphysematous. She had that change through all of her lobes, and she had a small right pleural effusion, numerous pulmonary opacities in both lungs, and this shows, yes, it was cancer or metastatic disease. So her current medical history is the same as her initial diagnosis, but also includes fibrosis of lungs, a granulocytosis secondary to cancer chemotherapy, neutropenia related to chemotherapy, and anemia. She had secondary malignancy of the upper lobe of the right lung, and, of course, because she was quite immunocompromised, herpes simplex virus. She was more susceptible to viruses, which is one reason this could have presented itself. So past medical history and current medical history, boom, they're connected due to her immunocompromised state, and this is related to her cancer diagnosis and treatment. This could be related as far back, or if not farther, all the way back to the breast cancer diagnosis. So what is the etiology of her disease? Well, she smoked, had breast cancer. She had a lot of family members with both lung and breast cancer. But we really don't know, was she around asbestos? What were her environmental factors? Could radon have been involved? Nutritional treatment. So prior to a diagnosis, I would have loved to see her get more antioxidants, so bright, colorful fruits and veggies. When she went into septic shock, of course, I would have helped her along this journey by recommending she was NPO, so nothing by mouth. If she was hemodynamically stable, then I would ask that she be put on a liberal diet with thin liquids. if SLP had signed off that she was not suffering from dysphagia, and if she wasn't reaching all of her protein goals or calorie goals, I would add Ensure, so 2 to 3 times per day. She had a very poor prognosis, but why? Well, like I said earlier, she was stage 4 bilateral lung cancer. She did have a little bit of unintentional weight loss, which you can see at the back of your packet. It was about 5 pounds. She went into septic shock. She had pulmonary fibrosis, so her lungs were really struggling when she was trying to breathe. She did have a UTI, and she had both family and past medical history. So adding fuel to the fire, our microbiology report, our blood cultures from 221 showed Klebsiella oxytosa and Enterobacter aerogenes and Cloacia. So fun fact, in microbiology in my undergrad, my mystery bacteria was actually Enterobacter aerogenes, and I do love those moments when life comes full circle. Surgical treatment, we didn't have any at this hospital stay, thank goodness, but we did have a lot of medications. So medications can be seen in the references 11 through 17. Her present illness and treatment, she had antibiotics, pain meds, hydration, steroids, anticoagulants, magnesium oxide, anticonvulsants, blood pressure meds to treat her hypotension, and she had a PPI. All of these things say, in combination, we need to avoid grapefruit products. Luckily, we don't really have that at the hospital. She needed to avoid kava kava, ginseng, garlic, echinacea, St. John's wort, gotu kola, milk thistle, valerian root, ginkgo biloba, vitamin E supplementation, mineral oil, and alcohol. Please see your reference section for medication details. There are a lot of details on those meds. With our medical treatment, yes, unfortunately, we did have to resort to hospice care for comfort care. So TK was marked as a pre-admit for hospice. This was on February 27th. This was roughly 7 minutes after I went up to talk to her. I wanted to fill in some of the gaps in her social history. And unfortunately, when I went to her room, I saw her having a coughing fit. Her family was surrounding her, and I knew it wasn't the best time to come talk to her. So I went back downstairs, and as soon as I opened her chart, I saw that she was marked for hospice. So for peer-reviewed articles, lung cancer with sepsis. If you have your phone available, please get your phone out, scan the QR code so you can read a little bit more about this awesome study. It was on the microbiome, dysbiosis, and cancer. So there is a great picture in that article of the lungs, but I just wanted to talk about something we're a little more familiar with to kind of get our feet wet before we dive in. So dysbiosis in the gut, so wrong amounts of certain bacteria and changes in the gut can actually be created from poor food choices. If you're dealing with obesity, if you're dealing with diabetes, it can also contribute to a lot of issues, including chronic inflammation. So pathogens can translocate, so they can move. For example, with lung cancer, if there's pathogens in the mouth, they can move to the lungs. Innate immune cells will be activated, and that's going to add cytokines to the mix, and we're going to get even more inflamed. Then we see environmental factors. So we see carcinogens, genetics, heavy metals. All of these things can result in issues in the gut. And what's really interesting is our vagus nerve, and of course I'm pointing, but I don't think you can see it. The vagus nerve and the gut actually connects all the way to the brain, and that's how that communicates. Your gut bacteria communicate all the way to your brain. So Article 1, and there's a link here if you didn't have your phone available, but we see a problem. We see microbiota or bacteria translocating into the lung. Diversity is becoming altered, and we're increasing the bacterial load. The result is going to be the creation of tumors. So this is in the lung tissue, and this is related to bacteria producing metabolites. So these metabolites include cytokines, interleukin 1 beta, and interleukin 23. When all of these metabolites happen, our cells begin to expand. This is related to neutrophil-induced inflammation. So white blood cells are coming in and they're trying to attack, but our cells are getting upset. They're getting really inflamed and really angry. Cytokines are forcing proliferation of lung cancer cells. So again, they're beginning to multiply. Metabolites are altering metabolism. And this is resulting in oncogenesis, or the creation of cancer cells. And we're supporting this. When I say we, I mean the bacteria, not myself. But this is supporting the habitat for oncogenic bacteria. And they thrive there. But they're not directly oncogenic. They're indirectly oncogenic because they're creating all of these metabolites and creating all this inflammation. So chronic inflammation creates a supportive habitat for these pathogens, and this triggers tumorigenesis. And the mechanism is actually unknown, which I found interesting. So more research is being done to figure out what is the mechanism. We've got some clinical issues here. So our problem, it's oral originated Prevotella and Veillonella, which they're both types of bacteria. Higher numbers are actually associated with higher lung inflammation and increased levels of cytokines, which is directly related to metabolites being created. So in practice, and I put a question mark because I honestly don't think that we're ready for this, but in theory, our heavy hitters would be altering the bacteria balance from firmicutes to proteobacteria, throwing antibiotics in the mix, and this is going to result in increased anti-tumor immunity. This is something we need. We do not want tumors. We are anti-tumor. So still on Article 1, we want to talk about what we know. We know bacteria are everywhere, even our lungs, which wasn't something that was on my radar initially. It makes sense saying it, and I feel silly for not thinking about it prior to, but it's really interesting to think that it literally is everywhere, every inch, centimeter, nook, and cranny of our bodies. But this also means that dysbiosis can occur anywhere in the body. So dysbiosis can lead to decreased immunity, increased likelihood of allergies, autoimmune disease, and, go figure, cancer. So what may help? Well, as dietitians, we're going to address diets. We're going to pay close attention to what medications are consumed. We are going to see about exposures to antigens and to stress, and this will determine what other factors to add to altered immune cancer axis. So immune cancer axis is something we really want to pay attention to. And something, honestly, dietitians, especially in the clinical setting, we need to know more about this. So we want to throw a huge caution because, as we know, humans are unique. I am not the same as you, who are not the same as you, who are not the same as you. And that means our microbiome's also not the same. Very unique. So this means that no one-size-fits-all approach is possible. We have to think about this globally, like I said earlier. So more research is actually needed to determine the epigenetic factors altering the diversity and balance of microbiota in the body, human or otherwise. There has been a lot of research on animals and regarding cancer. So with that said, the biggest takeaway from this slide is going to be, is a study done on humans or is the study done on animals? And how does this translate to a clinical setting? So more research is actually needed to understand the microbiome. It's only been talked about since about 2005. So less than 20 years now. But we also want to know, how does this affect the immune system and its tissues? Supplementing, helping, or harming is what we're going to talk about next. Please, again, get out your phone, scan the QR code, and let's dive in. Here you can click on the link as well, again, if you don't have your phone, but we're talking about beta carotene and cancer prevention. So this was a very large study. It massive. So it was from Finland, and men and females were involved, which is great because a lot of studies are just on one specific sex. So it's wonderful to see it on both sexes. This is only one example of how smokers supplementing with beta carotene may increase their lung cancer risk. This is not the first study to show this. This has been talked about for a very long time. Supplementing with beta carotene and increasing the risk of lung cancer as a smoker. So, no studies highlighted if there was an increased risk associated with supplementation, varying all depending on the tar and the nicotine content. So, tar and or nicotine content did not change the risk. That was really interesting to me because you would think that the higher the amount, the bigger the risk, but here they didn't see that. So this suggests that supplementing with beta carotene should continue to be avoided. So if you do have patients supplementing with beta carotene that are smokers, I would recommend that they discontinue this supplement routine. So my conclusion on lung cancer with sepsis: after further decomposition, TK's time of death was reported on February 28, 2024, and this was at 13:06. If you remember, she was only marked for hospice at February 27th, and it was about midday. So it's a bit alarming to me. Maybe not alarming, but a bit shocking to see the decomposition of my patient being so quick. In conclusion, on lung cancer with sepsis, we have proper screening being a huge deal. So it's so quick. It literally takes 25 seconds. And I just want to recap that because I didn't even know what populations were able to get this screening. And I honestly thought the screening would take a very long time. 25 seconds blows my mind. Everybody could spare 25 seconds, especially if you're at high risk for something as heavy hitting as lung cancer. So proper screening, again, decreases mortality or death by 6.7%. In the grand scheme of things, that's pretty significant. That number seems small here, but when we're talking about lung cancer, every bit helps. We want to prolong quality of life. Proper screening can do that. That is a huge deal for our patients because, as you saw, my case study patient TK went from being alert, oriented, awake, then all of a sudden going from being very on it with her ADLs and IADLs. She was septic. A few days later, she wasn't able to get out of bed, and she ended up passing away. So proper screening may save a life. Proper screening prior to showing signs and symptoms for TK, this would have been beneficial to her, and it honestly could have saved her life, especially with her high rates of lung cancer and breast cancer. I just want to throw breast cancer in the mix because she did suffer from both, and a lot of her family members did as well. But again, it could save a life if someone is higher risk or higher prevalence. So nutrition to treat and prevent is key. Nutrition is key. I think it was Hippocrates that said, let nutrition be thy medicine. Anti-inflammatory foods, so something with bright colors, fruits and veggies, lots of fiber. We want to get that protein and we want to get energy, especially after our patient has the cancer diagnosis. We really want to emphasize protein and energy. Fiber is just going to help them to reduce the risk of being septic or going septic, dealing with shock, because again, we are tightening up those gaps. We are lifting those little fiber weights. I always think of the gut just like curling fiber. And I always talk about that to all my patients. I talk about fiber all the time. It's one of the biggest things we can do. Fat increase and medium chain triglycerides are huge because, again, we want energy dense foods because most likely our patients are dealing with chemotherapy. And if they're not, they could still be dealing with nausea, vomiting, things that just genuinely make us not want to eat. It does not feel good to cram a bunch of food in us when we're nauseous. Am I right? Yeah. So, again, higher amounts of fat. We'd prefer some polyunsaturated fatty acids and some medium chain triglycerides. And to get people to eat or tolerate or enjoy food a little bit more, we could try the lemon trick again. Squeeze the day. That is my saying for this case study, my mantra. We want to do the lemon trick. That seems a little bit difficult in a clinical setting because you're going to have to put in a special request for lemons to be sent up with every tray, or the patient may have to. I don't know how realistic that would be in a clinical setting. It of course, will always depend on what hospital you're at. I have not actually heard if this is standard protocol at a place like Carmanos or somewhere that focuses more on cancer. But I do know that with my patients here at McLaren, I've been recommending lemon and I've been putting it in their preferred foods on their ADIME note. So that's one tip I can give. You can also recommend that family provide them with gum if they do have family. It would be a liability, most likely, if an RD or especially a student were to give a food item, which I consider gum a food item, to a patient. We're not allowed to do that. That's one thing that I would probably recommend to family if the family's there. Or, of course, everyone has their phones. See if their patient could maybe reach out to a family member if they're coming by. Prevention. So I talk about this last because it's one of the most important things we can do. We can talk about behavior change. Well, how do we do this? Motivational interviewing. We can talk about cessation of smoking. We can talk about education, whether that be education on lifestyle changes or education on nutrition. And we can also talk to the community, get them involved, community nutrition, but also focus on those behavior changes in the community. So the biggest thing I think of when I was a kid was going to restaurants all the time and everybody was smoking. Then all of a sudden in the community, there was a shift and now we have a smoking and non-smoking section. Another shift happened when you're no longer allowed to smoke inside our facility. And that's fantastic. And we need to see these shifts because it really determines the quality of life our patients are going to have. And our patients, meaning our entire community. If we don't see change in the community, we're most likely going to keep seeing the same issues. So again, I do want to mention the time of death for my patient was February 28th, 2024 at 13:06. In her doctor's note, her hospice note had mentioned that both her family and her hospice nurse were by her side. I had heard that our hospice nurse was absolutely fantastic. To my understanding, she guided my patient TK and allowed her to feel at peace when she had passed. So, and this was actually recorded that she went peacefully. My biggest takeaway. So this is kind of a heavy case study or a heavy way to finish my case study, but I want to put it on a good note where I always focus on the positive, especially at something this heavy. Focus on the importance of the interdisciplinary care team and their communication. And I just want to throw this reminder out there. This does include family because if our patient, for example, is septic and dealing with a UTI and not there cognitively, we want to rely on her family or his family, and we want to ask them whatever questions we can to figure out how to provide the best care for our patient. So my biggest reaction is that TK did have wonderful familial support, a wonderful care team, and her condition did decline all too quickly. I just want to say thank you, and do you have any questions?